Leonida, you can go ahead.
Thank you, Persis. So good morning or good evening to everyone else who's here today. I'm just going to give people a few more minutes to log in. So let's take about 2 minutes. And after that, we can all get settled and then we'll get right on with the webinar. So thank you all once again. I think I'll just start for the interest of time. So once again, good morning, good afternoon, depending on wherever you are joining us from. Thank you so much for logging on today. Thank you, for being here to join us for this panel discussion. Our theme is prioritizing women's health, addressing gaps in access and equity through innovation. And my name is Leonida Kombo. I am the Digital Communications Manager at Antara Health, and I will be moderating this engaging conversation with you all today. So joining me will be 5 experts on this topic who I am going to introduce in just a minute. We don't often get a chance to celebrate individuals as well as institutions for the roles that they've played in making healthcare more accessible to women and everybody else at large. And so I'd like to take this opportunity to thank our host, Via Global, for putting together this lovely session in honor of International Women's Day and Women's Month. For those of you who may not know what Via Global does, they are a global distribution channel for medical equipment and supplies, serving low and middle income countries and LMIC buyers who are often underserved by existing procurement and supply chains. So Via Global also partners with companies as well as products that are innovative to expand their visibility and impact from the work that they are doing. So I'd like to just start us off with a little bit of housekeeping to help you understand how the session is going to flow. For the first half of our session, I'll be posing questions to our panelists, and we'll have a lovely Q&A session thereafter. So don't forget to write your questions in the Q&A panel. So on your screen, you should be seeing some functions, some buttons on the top right corner of your screen. There should be a section there written questions. So once you write your questions in there, I should be able to review them. If I have enough time, I'll be able to read some of the questions during the call. If not, we'll just proceed to do the questions at the end during the Q&A session. In addition, this call is being recorded and it will be available on Via Global and Antara Health's YouTube channels. So now for the part that we've all been waiting for, we want to find out who our lovely, experienced and well-seasoned panelists are. So without any particular order, let me just actually start off by telling you who we have today. We have Dr. Harshad Sanghvi. We also have Gillian Henker here with us. She's the co-founder and president of SISU Global Health. We have with us Dr. Thomas Burke, who's the founder of Vayu Global Health. Dr. Anne Beatrice Kihara, who is the president-elect of FIGO, that is the International Federation of Gynecology and Obstetrics, and Rebecca Nyakundi, who is the founding team member and the care team operations lead at Antara Health. You may hear me calling her Becky. That is what we fondly call her where we work. So without further ado, I'd just like to go ahead and start. Do we have Dr. Harshad on the line?
Please move on to the rest.
Okay. So we have with us Gillian Henker. So Gillian is a two-time founder with a proven track record of execution. She is the primary inventor of HemaFuse, in addition to two other medical technologies. She's led the development of HemaFuse, global regulatory clearances, including FDA, and launched in 5 countries across Africa, Asia, and Europe. She's been published in the International Journal of Gynecology and Obstetrics and has presented at the Midwest Biomedical Engineering Career Conference and Appropriate Healthcare Technologies for Developing Countries seminar in London, and was named Baltimore Technologist of the Year. Gillian Henker, a word or two for the audience?
Just thank you for having me, and I'm excited to have the conversation here about women's health.
Thank you so much, Gillian. Sorry, one moment. Next with us, we have Dr. Thomas Burke. He is the founder of Vayu Global Health. He's also a director of Global Health Innovations Lab in the Department of Emergency Medicine at Massachusetts General Hospital, MGH, and an associate professor at Harvard Medical School and the Harvard T.H. Chan School of Public Health. After graduating from Albany Medical College in 1989, he completed his residency in emergency medicine at Madigan Army Medical Center, Fort Lewis. Dr. Burke spent 7.5 years in the U.S. Army, and over the time he was deployed with the Light Infantry as well as 2nd Ranger Battalion. Dr. Burke has been a tactical physician for the FBI hostage rescue team at both the hostage incidents in Waco, Texas, and Ruby Ridge, Idaho. And on September 11th, 2012, Dr. Burke was in Benghazi, Libya, when Ambassador Stevens lost his life. Dr. Burke's innovations research experience spans 25 years. Over that time, he's pioneered several award-winning scientific advances and translated them into policy and practice. Since 2004, the majority of his work has focused on maternal, newborn, and infant survival. So quite an interesting transition there. Dr. Burke has led a research program focused on postpartum hemorrhage for the past 10 years and co-chairs the International Federation of Obgyn Working Group on Postpartum Hemorrhage. Dr. Burke has also authored over 120 scientific manuscripts and is invited to speak at high-profile forums and leading universities around the world. He is a senior faculty in the Harvard University Center for African Studies and an active member of the Harvard Medical School Admissions Committee. So welcome, Dr. Thomas. Please share a quick word with our audience.
Thank you so much for having me, and listening to that. That's actually outdated by about 7 years, so I'll have to find out where that is online and update that. But thank you, and really looking forward to this discussion.
Thank you so much. I'd like to ask if we have Dr. Anne on the call. Is she present?
Not yet. Let's go with Becky.
To go ahead and wait for her. Meanwhile, we're going to introduce Becky. She is my teammate, actually. She's the care team operations lead at Antara Health. She has also been, or is also, a founding employee of Antara Health and has been its first health navigator. So Antara, for those of you who may not know, is reshaping what great healthcare looks like. It has been founded by experienced physician innovators and technology entrepreneurs. Antara marries sophisticated technology with a thoughtful care team experience for continuous personalized care that changes behavior, drives exceptional healthcare outcomes, and provides unprecedented convenience and satisfaction. Antara's platform enables people to make smart choices about their health and be supported throughout their entire healthcare journey. So Becky's previous career in healthcare spanned from outpatient care and claims management to research in key population management with an emphasis on women with HIV. At Antara, Rebecca has singularly been responsible for developing its health navigation service. In addition to developing the clinical protocols that underpin patient management, Rebecca also manages Antara's clinical team. She has been instrumental in rapidly scaling Antara's service while also maintaining Antara's product development team. Working closely with Antara's product development team. This collaboration has enabled essential innovation, which has defined Antara's service delivery. Rebecca also holds a Master's of Science in Health Systems Management and Leadership, as well as a Bachelor of Science in Nursing from the University of Nairobi. Welcome so much, Becky. Please share a word with our audience.
Thank you so much for this platform. I look forward to an engaged discussion.
Thank you, Becky. And just in case our two other panelists join us later on, I'd probably like to ask Persis, should I go ahead with the intros for Dr. Harshad as well as Dr. Anne? Or should we just go straight
Please introduce Dr. Harshad, who will be with us shortly, and then we can begin the questions.
Okay, in that case, we'll go ahead and introduce Dr. Harshad. He has had a 20-year academic career in obstetrics and gynecology in Kenya. He has spent 2 decades assisting 45 countries adopt innovative solutions to improve performance of healthcare for women. His team developed the single-visit approach for cervical cancer prevention, now practiced in 30 countries. In 2009, he received Global Health Council's Best Practices Award for his work in preventing postpartum hemorrhage at home birth, now practiced in 45 countries. He holds prestigious honorary fellowships of the Indian College of Obstetrics and Gynecology. Following his work with FOGSI, is expanding EMOC. He has conceptualized, developed, and deployed several disruptive health technologies. He recently retired as VP and Chief Medical Officer for JHPAGO, an affiliate of Johns Hopkins University, and now serves as in an emeritus position and is an advisor for the Center for Bioengineering Innovation and Design at Johns Hopkins University. Just like us all, to just take a moment to appreciate our panelists today. And right now we can get into the heart of the matter. So I'd like to actually start off by asking our panelists, and in no particular order, what are some of the biggest gaps in access to women's healthcare globally, and how can we innovate to help address some of these gaps? I think we could probably start off with Dr. Thomas.
Well, thank you for asking. I mean, that's really, the big holy grail question, I think, and it's a good place to start. And so briefly, I think there are multiple gaps, and overall they contribute to what today remains an unacceptable maternal mortality and outcomes. So overall, on the global stage, there's still a lack of prioritization in terms of the health and well-being of women, and especially pregnant, surrounding pregnancy. and that's across even the most developed nations. So there's a lack of enough policy. There's certainly a lack of cultural, we aren't where we need to be and want to be when it comes to cultural competency and cultural importance of women's sexual rights and independence, and then also safety around pregnancy and being able to control pregnancy. And there isn't yet the finance that needs to be. If we look at other similar global issues, there's a really different level of equity around finance. Certainly, a lack of access to fertility control is a big one. And I think we all know that being able to have access and independent access to contraception is really critical to women's empowerment and being able to improve outcomes. I would say lack of access to quality care and lack of access to care overall. So the institutional delivery rates are key in helping us understand and the quality of care that women receive in those institutions and around appropriate care. And then there's the tools and equipment, training, human resources, human behavior, all of these interventions into all of these that are appropriate can make a difference. But all of these link together, I think, into the chain of survival, the chain of quality and care for women. So any innovation which directs either tools, equipment, policy, finance, changes and improvements in human behavior. Postpartum hemorrhage, the area where I spend a lot of time in, we understand that if we put together and fix all of the different pieces, still the human behavior piece is one that's missing, monitoring women after delivery, et cetera. So I think there's an enormous opportunity, multiple different areas of this chain of what's necessary for women to have quality health care.
Thank you, Dr. Thomas. You really brought out a very interesting point, which is, of course, there are different pieces. And the interesting thing is that we have two other panelists here with us who can actually address some of those extra pieces. You spoke of, for instance, the access to healthcare. And in another instance, you spoke of even the tools and equipment needed. And I feel like I'd like to hear what Gillian would have to say, particularly about the tools and equipment that are required to help innovate and address these gaps. And of course, Becky, after that, I'd also like to hear your take on how the access to care can be improved upon. So take us away, Gillian.
Yes, no, and the point that I take from Dr. Burke's assessment is also resources. So for us and the innovation that we do, it's about not only having, giving and providing resources where there are none, but also making it faster to avoid delays, as well as to provide it cost effectively and with task shifting to folks that don't need to necessarily be trained or to have it where with who's there. So if there are only 2 people in a surgical suite, you can still use this device without needing to have 6. So for us, it's all about resources, and we think that in being able to have an innovation that provides greater resources, or to be able to work in low resource situations, it's going to be able to provide access and life-giving resource, which in our case at CSU, our first device is around blood. So, and the fact that in women's health, whenever you talk to the lab about who's calling the most for blood, it's usually the OBGYNs. So that's where, for us, it's all about increasing those resources to close that gap as much as possible.
Thank you for that, Gillian. And of course, Rebecca, yours was basically to tackle the issue of access to healthcare. What are some of the ways that people can innovate to address that gap?
The access to healthcare from the part of the world where I come from, especially boiling down to Kenya, definitely our social strata also affects the access and equally the facilities that we have. And most of the innovations that are around are focused on making sure that all women are able to at least be seen by a healthcare worker. And we have telemedicine services that are being offered across board because we are also looking at the catastrophic cost of care that always lingers around those who are coming from low middle income countries or developing countries, to say so. And looking at that, if they can have that telehealth service, and equally innovations around mapping, geo-mapping, where providers are looking at in the African setup where facilities, specialists are very, very sparsely populated. And using technology and innovation, we are able to map where specialists are and direct women appropriately so that they can be able to access these services. Also looking at the bio devices that we use for tracking and monitoring. These are things that that woman way back in the village can be able to use and can still access healthcare. And this has really helped tremendously to improve and also bridge the gap that is there in access of healthcare.
Thank you, Becky. I'm hearing a lot of pointers from you, which are very, very true in this particular case. When we're talking about the cost of care, particularly within these low and middle income countries, they can have very drastic effects on families and our economy as a whole as a result. And so with that, I'd like to go to the next question, which is, how can we ensure that innovation in women's healthcare is inclusive and equitable and does not exacerbate existing disparities? Becky, you particularly spoke about, the issue of cost in care, and maybe you would want to speak a bit more to that and give us some more insight as well.
The cost of care definitely is something that is at the forefront when we talk about affordable healthcare, because it's a huge gap and a hindrance when we are accessing healthcare services, especially as women. And looking at the cost of care, are you able to manage your utilization? Because if I don't have an insurance cover to cater for my needs as a woman, looking at the part of this world where we come from, basically what has been the focus, sexual and reproductive health, most of the insurance companies do not cover for that, do not cater for that. So someone has to deeply go into their pockets, and everyone is looking at what are the fee for service is very, very high. And when a lady looks at that, then they get that retraction from going to a facility. And besides the sexual and reproductive health matters that touch on women, there are other aspects of health, not the non-communicable diseases, and early detection across board, be it in women and men, is very key. And that is something that should definitely be integrated when we are bridging the gap in accessing women healthcare. And that early detection of risks, cardiovascular conditions that could be there, helps a lot, so that someone is able to manage their condition and reduce the cost of care at the end of the day.
Thank you, Becky. And actually, you've touched on a point that Dr. Thomas Burke at some point had mentioned. I do recall you mentioned something concerning policy, especially where, sexual and reproduction, health is concerned. Maybe how policies can be made to make healthcare more inclusive to women. Speak a little bit more on that point for us, please. Hello?
I'm sorry, who are you asking?
I'm asking you actually.
Oh, can you repeat? I'm
yes.
sorry, I didn't know what you asked me. I apologize.
Again, it's okay. So Becky has made a very interesting point here about how, you know, it's very hard to make things more equitable in the space of you know, women's health, especially pertaining to sexual health and reproduction. And you did actually mention that when we were talking earlier about, you know, what are some of the things that we can innovate around to address the gaps in women's access to healthcare. So speak a little bit more on that.
Yeah, absolutely. So I think there are a couple of different ways, but I mean, I think the first one is that at the national level, there needs to be policy and laws that allow for accountability around equity and allow for you know, a structure and a platform that can help push you know, the population towards a demand of equity. As just described, you know, there's been a movement in some countries to have universal health coverage for and especially for women, it's pregnancy and for prenatal care, and then also for delivery services. But that's absolutely not universal, and still an enormous problem. So that means that the most vulnerable women are those that with the least resources. So finance is really critical, whether that's mandating insurance, national health insurance, or some fashion in order to make sure that finance follows policy. Then I think all of us in this space, everything that we can do to support, you know, leadership. You know, Ann Kihara is a great example. I mean, everything we can do, FIGO can do to support Ann and the voice of FIGO and then also, you know, the midwifery community globally to really that equity is somebody's dog is joined. Anyway, you know, that really is critical that we strengthen and support leaders that then subsequently can strengthen and support at the community level and the local level on down. So and then innovation, even all the way down to devices and ensuring that that if we can make things affordable for the most low resource settings and make innovations and tools and behaviors, ones that can be well, you know, implemented even by those that may be illiterate, that will allow populations in the most low resource settings to actually access quality care.
Thank you, Thomas. And actually, Gillian, you had also mentioned something very similar to what Dr. Thomas Burke has just mentioned. You were earlier talking about, you know, innovation and how it should be able to, you know, as we're working on innovations, we should be able to work with them in a low resource environment. Maybe could you clarify what you meant and related to how we can ensure that innovation in women's healthcare is inclusive and equitable?
Yeah, so I will say that for our device designs that we do, it's all about feedback and inclusivity with our users and every point of the value chain as well, right? So our hemofuse device was made not only with nurses on the surgical side, OBGYNs, surgeons, but learning and observing and testing through all the different ways that this can also be used with you know, even support staff on like the cleaning and sterilization end. So making sure that there's no barriers to use for a device like this. And I will say that our device is used mostly from OBGYNs who are always looking for blood for their patients on surgical cases. So for us, though, it's also that our device, when it's used, that means that, you know, the blood that is collected and transfused to that one person there's any other blood on hand, that blood can then be reallocated to someone outside of surgery. So it's always about increasing the blood resource completely across the board, so that if someone in labor and delivery where our device isn't, used in surgery, that blood can then be given and free up resources to serve those patients. So it's all about increasing the number of resources, as well as being able to use a very simple device that can go into any surgical suite. And our device is very simple, and that's very much a compliment to say that it can be used anywhere there's a surgical case. So that's something we pride ourselves on from a design standpoint.
Thank you. It definitely does sound like something that is simple enough to also fit into multiple use cases. I wanted to just remind the audience that we have the question and answer section. So if there's anything that you have any question on, to our panelists and they've not probably addressed it, please take your time to write us a comment, or rather write us a question in the question section. So this should be in the panel on the top right section of your screen. I will be looking at this periodically and inserting it into this conversation. If not, I'll also just do a question and answer round at the end of this session. So with that being said, I'd like us to move on to the next question. So the next question is about, cultural and social barriers. So I'd like to ask specifically, what are some of these social or cultural barriers that have prevented women from accessing the care that they need, and how can these be addressed through innovation? So I'd like to start off with Rebecca on this question.
Social cultural barriers, I think for women, I'd say most of that is a reflection of the population that women are in the world, and there are so many and varied. Looking at culturally, socially, majorly when you look at our religious beliefs, have been a great have greatly affected the way women majorly access healthcare. Similarly, the beliefs that we have in terms of where we come from, the tribes we come from, the family units we come from, where be the setups that we have in Africa or any other country around. As Rebecca, I might not be attended to by Dr. Burke, because Dr. Burke is a male, and yet I need that service. Those are very huge things that have brought up the gap and also affected healthcare services and access to women. But innovation has helped, where we find as a specialist, we are using telehealth to be able, and video conferencing and everything, to be able to even diagnose women who could be having such barriers because they cannot associate with a physician of the opposite sex, or also with the background that I've had when it comes to reproductive health. I did a public health campaign in a minority community where I come from in Kenya. And in this instance, the women are not allowed to participate in family planning. And any conversation on reproductive health is a taboo in their families. But you looked at the women's despair, and they really needed help because they had to be in good health, because the gap, the reproductive gap was very, very close for the number of children that they were having. And at the end of it, we were having a lot of maternal mortalities. And so innovation really helped in the sense that the devices that were there, and also accessibility, telemedicine that we were able to use to reach out to these women. And thanks to the likes of Gillian, whatever they're doing is very brilliant, because such technology is needed on this side of the world to help these women be able to access care, because they're really in need. And that would hugely reduce maternal mortality.
Thank you, Becky, for sharing with us how, these beliefs are actually linked to, infant mortality and several other challenges that we're experiencing and talking about today. And Dr. Thomas Burke, I am also very curious to hear perhaps the difference between, some of these cultural barriers that we've just discussed that, Becky has highlighted, mostly from these low and middle income countries, and how are they different perhaps from the way they are in the West? Would you say that it's also a really large contributing factor?
Absolutely. In the United States, maternal mortality is now increased considerably. In this past year, it's, I think, at a 20-year high. And absolutely disparity, wealth disparity is probably, and the lack of equity is the greatest contributor towards maternal outcome disparity in the Western Hemisphere. So in high-income countries, I mean, we see very similarly that women that may not have access to the same financial resources, or women of color, or women that are from a different cultural background, oftentimes are marginalized and don't have access to quality care. So it really is, it looks different, but it's, a bit from each setting, but in many ways it's a very similar theme.
That's very interesting to hear how they're more or less different, but having a very similar, effect. And maybe Gillian, would you like to add to that?
Yes, I'll just say from some of our early use cases of hemofuse, I was surprised that one of our main cases was or is ruptured ectopic pregnancies. So that's when you have internal bleeding into the abdomen. And all of these clinicians would always say, oh, they always come at night. So it's these women who, would grit through it all day, but then at night they would come to the facility. But of course, most people had gone home, and you're working with a skeleton crew. So our device was being used the most when women would come at night with these massive hemorrhages and the lab is closed, don't know where you're going to get blood. So our device was the best option at the time. So I thought that was very interesting to say, why are these women mostly coming at night after the day and not able to come during the day? Probably cultural barriers there as well. That was just very surprising, where our device could assist when, again, they're coming so late in the night.
Thank you, Gillian. That is just a very real, manifestation of some of these cultural differences that we have, and, some of the actions that they make people take, unfortunately, that could endanger their lives. And it's really great. And this is exactly why we're having this conversation today, to just talk about how each and every one of you has actually, innovated around some of these cultural barriers. And it's just very interesting to hear your unique stories on the same. So the next question that I have for you is, how can we ensure that women's healthcare is integrated into broader health systems and not siloed or neglected? I especially heard you, Dr. Thomas, talking about, policies. Maybe you could also expound on that, or share anything else that you have to say on how to broaden health systems.
Yeah, thank you for asking this question. This is a very important one when we look across systems of care, and there are glaring examples. HIV, certainly one of them, where there was stovepiping and siloing, and maternal mortality, increased at the time when suddenly, massive resources and energy appropriately were put into HIV care, but then women were left behind. Actually, the same thing happened during COVID, and it happened, worldwide, where maternal and newborn mortality went up, and not directly COVID related, but in great part because COVID pulled so many resources and so much attention. So it's really important that we think of systems of care much more than any, while specific innovations, of course, are helpful, they're not helpful if they're not integrated. They're not helpful if they're appropriate for their setting. They're not helpful if they're left on a shelf or locked in a closet. If they're not helpful if people don't know how to use them, or if there are cultural barriers around them. So it's really important to think of innovations as ones that are holistic and ones that are inclusive. Our team at Mass General Hospital, working closely together with midwives and OBGYNs in both Kenya and India, and then also with FIGO, International Federation of OBGYN, as well as midwives. We designed something called the Postpartum Hemorrhage Emergency Care Package, which now is in multiple states in India. It's in Kenya. It's become a national policy in Kenya, I understand, and then several other, Pakistan, Bangladesh, and then also in Central America. And the point of that is it focuses on teamwork, monitoring, early response, communication, leadership, transport, facility readiness. Yes, the centerpiece includes the non-pneumatic anti-shock garment, the uterine balloon, which we designed. However, without the context and without all of those other, facility readiness and transport and leadership, without all those other sort of more holistic components, we find that the devices themselves don't really move the needle. But all these other components move the needle for the entire system. So it's not then just maternal survival, but then that affects survival in so many other aspects of quality care. So I think it's really important that we are careful about the ripple effects that are negative when we focus too narrowly on a particular device or a particular topic, if we don't think more broadly of how this integrates into the system and how it affects other components. Because, for example, transfusion is not just in maternal health, but there's trauma. There's so many other opportunities for Gillian and her work to have a positive impact, and obviously leadership is the same way, facility readiness is the same way. So anyway, so that's, I think we have to really force ourselves not to get too myopic and think too narrowly, but make sure that we think about the impact of what we do on other aspects of quality care.
Thank you so much, Dr. Thomas, for actually breaking down some of those components and showing that, if we look at them, as far as the bigger picture is concerned, we're able to get a more positive impact. I've just been informed that one of our panelists have joined us. Let me just go ahead and introduce him really quickly. Dr. Hashad, are you there?
Yes.
Great. I'd just like to introduce you briefly before we continue.
Thank you, and my apologies. All right, so just go ahead.
No problem. I think I had already introduced Dr. Hashad Sangbi before, but let me go ahead and just do it again for those of us who probably didn't hear and would like a bit of context before we continue. Dr. Hashad has had a 20-year clinical and academic career in obstetrics and gynecology in Kenya. He's also spent 2 decades assisting 45 countries adopt innovative solutions to improve the performance of healthcare for women. His team developed a single-visit approach for cervical cancer prevention, now practiced in 30 countries. In 2009, he received Global Health Council's Best Practices Award for his work in preventing postpartum hemorrhage at home birth, which is also now practiced in 45 countries. He holds the prestigious honorary fellowship of the Indian College of Obstetrics and Gynecology following his work through FOGSI and is expanding EMOC. He has conceptualized, developed, and deployed several disruptive health technologies. He recently retired as VP and Chief Medical Officer for JHPAGO, an affiliate of Johns Hopkins University, and now serves in an emeritus position and is an advisor for the Center of Bioengineering Innovation and Design at Johns Hopkins University. Dr. Harshad, welcome.
Thank you so much.
Thank you so much. And I think at this point, maybe I'll just throw you into the deep end. We already started our panel session. And right now we were addressing the question, which is how can we ensure that women's healthcare is integrated into broader health systems and not just siloed or neglected?
Yeah, well, thank you very much. And my apologies again to all my colleagues and my friends who are on the panel and elsewhere. Yeah, I think about being siloed or being integrated, because both have those challenges. I think on the one hand, having a narrower focus for our advocacy, our policy on women's health and pushing that agenda is important. On the other hand, being part of a bigger healthcare system is equally important. I believe that from a grassroots level and from a top-down level, at both levels, we need to continue to emphasize women's health care and the creative solutions that are now periodically coming out that can make a real big difference. My concern is that almost all the stories about health in Africa and maybe Asia and some other parts of the world are sort of negative stories. And I believe that we can do a lot better with positive stories. I visited a hospital here in Coast General where one of the technologies of one of your panelists was in use, and they were so enthusiastic about this new technology for providing better respiration for children, for newborns, and they were excited that it didn't use electricity and power and other things, and they were saving lives. These are good stories. We need to tell these good stories so that people can understand that the interventions that are being designed for women's health are producing big results and can fit into the mainstream of healthcare. I think sometimes people don't hear enough about the successes, and then we become siloed because the policymakers do not believe sufficiently that these solutions are going to help. I think we need to change the narrative and speak about the positive aspects of our solutions, the impact they are having, and I think then we will not be a siloed part of healthcare.
Thank you so much, Dr. Harshad. Indeed, the narrative is very important, and it's the small actions that we do, including talks such as this, that just make it a bit more clear how different people are tackling some of these challenges and making it known that everyone can have a part to play in making things a lot better. So I think I'd also like to hear what Gillian would have to say about this. How do you feel or how do you think that women's healthcare can be integrated into broader health systems?
Yes, so I would say for us, we kind of started out our device as being more focused on strictly maternal health, but then have really migrated into also the safe surgery space, right? So seeing our device as integrated into surgical care broadly. So seeing how, yes, it is still grabbed mostly by OBGYNs or folks that are in women's health, but also seeing how it's been used across, like, for even elective surgeries in orthopedic or in, trauma surgeries where you have, emergency, like, hemoperitoneum. So that's where our device, we kind of see it as, okay, it's not just women's healthcare. That might be where it's most used, but it really is, for a healthcare strengthening perspective, we see it best as a surgical solution across the board that then has effects, indirect and direct, on women's health by providing more blood resources across the board.
Thank you so much. I don't know, Becky, if you may have any point that you'd also like to share to the same, which is, how to ensure that women's healthcare is integrated into broader health systems.
Yeah, just to pick up from where Gillian has left in terms of healthcare system strengthening, I'd pick that up and touch on the human resource for health in terms of the training of the workers. How are we able to educate and make sure that all the facets of medical workers who are offering and delivering services also have an upper hand in terms of using the tools that are being generated and that are being created, and also being behind the thought process when it comes to the innovations and manufacturing of these tools. That is definitely very, very key to be able to see that there's integration in the system.
Thank you so much. So I'd like us to move on to the next question, which is how can we measure the impact of innovation in women's healthcare, and what metrics should we use to evaluate success? I'm particularly keen on hearing how you would answer this, Dr. Thomas Burke.
Well, thank you for that question. Well, the gold standard certainly in looking at maternal mortality is indeed the maternal mortality ratio, which is the survival of women per 100,000 live births. But there are many other features, of course, around women's health that go beyond maternal survival from pregnancy, but it really is the sort of the centerpiece. It tells us really the value that's being placed on women's lives and the emphasis being placed on quality care. But it's difficult. Per 100,000 live births, it's very difficult actually to measure that, certainly in regional or community level interventions. But we can look at surrogates. We can look at important ones, I think, that we would all agree on. We can look at how much policy is there around support and advocacy for women's finance and survival, and as we spoke on earlier, finance in support of women's sexual and reproductive health in terms of delivery services, and is there universal coverage for delivery services in a particular country. We can look at the effectiveness of these. Are people paying attention? There are many countries that there might be this notion that there is universal coverage, but then there are all these other charges at the local level that are barriers to women gaining quality care. As simple as there might even be, I've heard this over and over again, where a woman suddenly hemorrhages and then the family has to go buy a uterine balloon before they could use the uterine balloon, or a non-automatic shock trouser before they could use a non-automatic shock trouser to save her life. And we can look at other surrogates such as neonatal mortality. We know that mothers and babies are a unit, and if babies aren't surviving, we know there's a distinct problem in the quality of care. We can look at facility delivery rates in a particular area, and if women are not able to access care for what variety of reasons, they're not delivering in facilities, we know that's an issue. We can look at human resource availability, and the human resources, are midwives distributed, are OBGYNs available? Is there quality care standard in terms of training and knowledge? Transport systems, and then the commodity availability and supply chain for these innovations that are, the products that are necessary for sexual and reproductive health. So I think there are many ways that we can actually measure and develop various metrics looking at the at how we're doing in terms of serving the women's needs.
Thank you for breaking down all those different components and the different metrics that we can use to measure them. Gillian Henker, I'm also very particularly keen on hearing, what metric, for example, you find most important, particularly around the innovations that you've made with all the equipment that you've done. What particular, metric strikes you as the most important for just measuring the impact on women's healthcare?
So for us as a company, we do more what we call post-market surveillance. So just seeing and getting feedback from the market. And typically we're looking at, of course, any mortalities or anything related to that, which we haven't seen any. All of our patients that our device has been used on have survived and thrived, which is great news to us, as well as the units of blood. So one of my favorite things is, I was in a case where they were using our device and they finally came up with a couple of units of blood from the lab, and the anesthesia team said, oh, we don't need that. We have several units already here being, ready to transfuse. So the fact that, again, we track usually units of blood and even types of blood. So again, it's usually the rarer blood types or, the O types that our device is used the most on that don't have those matches. So so we typically go for, again, those resources. We are now starting to look and design ways for us to study again at a broader level, the healthcare strengthening side. We found a hospital told us, hey, we reduced our maternal mortality by over 70% in the first year of using your device. Now that's not directly using our device per se, but that's, again, what we see is increasing the blood so they don't have to take and ask an ambulance to go to the national hospital to grab some units and come all the way back and have that patient waiting. So we're looking at ways, and anyone who wants to collaborate, to look at studying the broader system outside of just that individual patient impact. And again, we've gotten it anecdotally. We'd love to increase our awareness of how this is affecting more at that system level at an institution, as well as potentially at a national level, with blood resources being a challenge across the board.
Thank you, Gillian, for that. I'm also keen on hearing from Dr. Harshad, in your experience, how can you measure the impact of innovation in women's healthcare?
Thank you. I think I pretty much agree with Thomas and Gillian, but let me look at it from three different perspectives and really focus on how we can get the system to listen to the information and the data, and what useful would be for the system to listen to this data. And so if you look at from patient's perspective, I think obviously patient wants to get better. And I think it's so critical in our metrics to measure what patients think about the care or the innovation, the care with the innovation or the technology or the solution that we brought. And that aspect is particularly important because patients speak to each other. They can be a grassroots support for your products and the type of care they received. So that would be one characteristic. I think the second part is what the providers themselves feel. Did the technology or the innovation make it simpler for the physician or the nurse or the provider to do their job? Was it safe in their hands, and could they ensure that it was safe? And then was it effective? I think these perspectives of providers are critical information we need, measures we need to have. And finally, I think we also need to have measures that influence the payers, people who pay for care, maybe insurance companies or governments or big organizations. And I think they would certainly be interested in metrics that look at cost effectiveness, comparisons of one technology against other. Um, they would be interested in knowing, is this measure consistent? Do we get breakdown in equipment more often or less often? Now, these are all secondary measures of impact, in my opinion, but I believe that they are really critical in getting adoption, in getting women to access these services, and in making, the final ultimate result we want, which is reduction in mortality and morbidity. So those would be, in my opinion, really important steps toward getting the impact information.
Thank you. I believe so too. Ultimately, that's exactly what we want to measure at the end of the day, which is the impact, especially on the reduction of mortality. And Becky, I'd like to also hear what you'd like to say as far as, the impact, how we can measure the impact of women's healthcare, particularly from your experience.
Just picking up from what the rest have said, measuring that impact, one is also looking at the uptick of whatever services and innovations that have been put in, and also the outcomes that are there. Health outcomes definitely are a big thing. Because when you look at non-communicable diseases, how are the women performing in that area? What are the outcomes from the interventions that are also being implemented using the various innovations and tools that are there? And this we can only get if we are also keen on how we have structured our data in terms of our health information. And that data is what is able to drive a lot of key decisions, is able to help us see, is there any progress that we are making in the health sector?
Thank you for sharing that, Becky. We definitely do need to have insight in this. And just as you had said, Dr. Thomas, at the end of the day, we need to be able to have good visibility across various areas so that we're able to drive the change that is desired. So on to the next question, which is, what are some examples of successful collaborations between different stakeholders in the field of women's healthcare innovation, and what lessons can be learned from these collaborations? Now, all of you have very, varied experiences, particularly because you've been working in very different areas. And so I'm very keen to hear from each of you, how some of these collaborations can work. I think, Gillian, I'll start with you because I'm very sure that there's a lot of collaborations that you've had to make, to make your, your technology actually hit the ground. So maybe you'd want to elaborate a bit on that.
Yes. So again, my background's in engineering. So this device, our first device, Hemofuse. I started out with a sketch of it in talking to OBGYNs and nurses in Komfenoche Teaching Hospital in Ghana, all the way through concept designs and 3D printed prototypes that I came back with and worked with them on the development of that, then through manufacturing and having this made more so in the United States at the moment, then through all the regulatory and testing and all of that work to then have it first used in folks at Kiambu Hospital in Kenya. So a lot of blood, sweat, and tears, pun not intended, to get through there, and a lot of great collaborations and funders as well. We start out with USAID Saving Lives at Birth grant, and was able to then go through all these steps to get our device in use. So great work and collaborations. Even now with a lot of the hospitals that are using our device, we see them as partners who we want to serve and create a great impact with. So right now we work a lot with distributors and hospitals at the moment as we roll this out. And even with, I will say one of our big collaborations we did recently was to get our device into Ukraine. Now we haven't gotten a lot of feedback from the uses in Ukraine, just one cardiovascular surgeon who said he has been using it, but this is where the collaborations we had to get it into those situations for those who need it there has been great in the last year. So it takes a monumental effort and lifting on so many different sides and many different stakeholders to just get our one little device into the hands of folks that need it. I imagine most people on this call who will go after me here have much more diversity and impact as well in the work that they're doing. So for me, it's pretty narrow, but a lot of heavy lifting on all sides.
Thank you, Gillian. And, Becky, just as, Gillian has shared about having to navigate and work with several several stakeholders. In your instance, especially as one of the founding members of Antara, maybe how can you say that you have been able to successfully collaborate with several stakeholders, to improve women's access to care?
Yeah, definitely to see this as a success, there has been immense collaboration, starting from even the pairs themselves. In this case, I'll even talk about their insurance.
Becky, are you there?
Yes. Can you hear me? Are we good? Yeah. So looking at stakeholders like insurance companies, where we have collaborated, picking out majorly, definitely the payers concerned about utilization of medical covers and financing of health, so that people can access it. And in light of universal health coverage, that collaboration has really helped, because we are able to determine, using data, the trends of accessing healthcare at the end of the day, so that we are able to put up programs that are geared to helping women, or even everyone, access care. Leave alone that, the provider side, we have point of care diagnostic tests that I'd say have really helped, because as we reach out to women, we reach out to anyone who's accessing healthcare, we are able to do the point of care tests and map out their care. I could be expectant or pregnant as a woman, but this really helps in assessing and monitoring beyond just the state in which you are in, that is pregnancy at that particular moment. Is there something else happening? It could be gestational diabetes or something else. Yeah, so that collaboration has really been integral. Even looking at other stakeholders when it comes to developing of tools that can be used. We have brilliant people who are good with data, brilliant people who are good with software and engineering, and have really helped in creating the diagnostic decision trees algorithms that definitely touch on other areas of health for women, and not only specifically touching on sexual and reproductive health, so that holistically a woman can be taken care of when they are seeking for health services.
Thank you, Becky. That was a very comprehensive response. We've seen, how all these different components interact, and we've seen exactly how important it is to collaborate across all those stakeholders. I'm also very curious to hear how Dr. Harshad has collaborated, especially throughout his career, to make healthcare more accessible to women?
Oh, very good. So I believe that there are a number of areas and we have to find very many different types of collaborations. But let me address one which I think bothers me considerably. It's in the development of novel technologies and solutions, and how long it takes for all of us to get from understanding the problem all the way to delivering the solution to people. And part of the challenge is that we tend to work in different domains rather than working together with a number of things. I believe that of the innovations that we have been able to bring to the healthcare scenario, some of the most rapid innovations came because engineers, public health professionals, policymakers, manufacturers, and end users all sort of came together at the start of the development of the solution. They each had different roles to play at that time. So, for example, the end users had the role of informing what they needed in the solution. Then the engineers had a role in inventing the solution, and others may have had little role. But they were all engaged in this right from the get-go. And not as if now you sort of, an engineer has created a solution, then they're looking for a manufacturer, then the manufacturer has to go and do their thing, then they're looking for policymakers. I think personally that results in many years passing. If we can all come together around a particular problem, then we can do that. And there are some very good examples. So I think that's one point that I'd like to make. How I think innovators all need to foster this collaboration from the get-go, not in sequence, but right from the get-go. The second part that I would like to say is now in terms of using solutions, I think we need to build very strong partnerships with the earliest adopters. And I think of earliest adopters often either in professional associations or in training institutions, especially pre-service training institutions. About 50% of what I practice today was taught to me by my professor, Professor Marty, and other people here at the University of Nairobi for many years. And I'm reluctant to adopt new things till I've sort of vetted that a lot more. So I think pre-service institutions and your professors and your teachers have an oversized influence on how you practice. And I think it's critical that we launch our innovations and create partnerships with pre-service institutions, with professional associations, so that there is a buy-in quickly from the professionals. And I think that the notion that if you build it and people will come just doesn't work. Somebody has to drive it. And I think early adopters drive it because they're not afraid to try new things. And people look up to them and they are able to adopt those technologies. The last thing I want to say is we sometimes forget that, especially in Africa, there's a big role that civil society plays. When we were working on cervical cancer, we couldn't get the hospital system to buy the new equipment, the cryotherapy equipment that we needed. But we got the Rotary Club to do that. They adopted individual nurses in schools. They helped to train them. They helped to equip them and spread the technology in that way. So there are many such service organizations in Kenya and rest of Africa. The Lions right now have huge investment in eye care. Rotary had investment in the novel technologies that are called the Jaipur foot. I think we need to figure out how women's health technologies get attracted to some of these civil society groups that really have an ability to at least launch our products, and then it starts becoming available to the most needy users.
Thank you so much, Dr. Harshad. And it's very interesting, what you're talking about concerning, quick buy-in to begin with from professionals. I mean, it's also what basically ties together everything else that you're saying, being able to foster that collaboration across various stakeholders, from the very start. It all starts from, quick adoption and quick buy-in. So this is a very interesting insight to get from you. Dr. Thomas, I'd also like to hear what you think about, you know, some of the successful collaborations between different stakeholders and how that can, you know, contribute to women's health.
Yeah, thank you. I don't have a lot to add. A lot of really important points were just raised. And I think I'll, just put in a strong statement that in order to have any hope for scale, collaboration is necessary. And I think just as Harsha described, collaboration is necessary much more broadly than I think many people have traditionally thought of it. And early is critical, no question. And we humans usually get in our own way more than any other barrier. So without collaboration, people behave in ways that are obstruction. We become our own barriers with, whether it's competing for resources, whether it's competing just for a voice, whether it's for whatever reasons, we become our own barriers. So I think early on, broadly looking at collaboration, because collaboration translates to political will, it translates to early adoption, it translates to quality in terms of rapid feedback loops that allow you to improve on your innovation. So I agree with what's been said. Thank you.
Thank you. We've definitely gotten that strong pointer that you've mentioned about, how collaboration is necessary. Otherwise, we actually become the barriers ourselves. And actually, we're drawing very pretty close to the end of this webinar. We just have one more question to the audience. Just in case anybody has any questions, remember that you can always type in your question at the top right panel, and we'll read them after this. So if there's any particular burning question that you have for any of our panelists, please make use of that resource. So without further ado, I'd like to ask the very last question. I think in this case, we can make a little joke and say that the first shall be the last, or the last shall be the first. Dr. Harshad, I think you'll be the first person that I'll ask the last question. So what do you see as the key defining success factors for innovative products to close the gap in access and equity?
Well, thank you for letting me speak on this. I used to, for the longest time, I was driven by measures of effectiveness. And I've realized that in addition to effectiveness, we need so many other ways to define our success. Let me start with one that may not be obvious to people. I think this is commercial success. I think the COVID pandemic actually showed us how critical supply chains were. And if we do not have the technology, we can't save lives. So we need to ensure that people who work many, many years in creating these solutions, collaborations that are occurring everywhere, need to find commercial success so that we can ensure availability at price points that people can afford. And I think that's so critical, and sometimes people forget this, and especially public health professionals like myself downplay that angle. And I think that is actually wrong. Public health professionals need to support the private manufacturing industry so that they can produce good quality products, effective products, and make sure that those brilliant inventions then are able to reach people. So I think that is number one on my list. I certainly believe that another measure of success is your market share with the product. Today, we may have many different options for treating the same thing. I think we need, as innovators, we need to think about how good our invention may be in terms of how much market success we've had. Again, as a physician, I only learned recently these kinds of words, but I believe that they are critical. And of course, it is, how many lives we have saved is critical in this. But I often think that a truly successful innovation is about how successful were we in meeting the unmet need. And I believe that, for example, let me just give you an example. I think that in the last 10 years, we have developed a number of very elegant solutions for preventing postpartum hemorrhage and treating postpartum hemorrhage. Thomas's invention and Gillian's invention are among several inventions. We can detect postpartum hemorrhage, for example. We can treat it. We can prevent it. We can, reduce its impact with a number of technologies that are there, many of them very low cost. But a lot of those technologies are not reaching the people that most need it. So in my opinion, one of the measures that we have to do is really estimate what the unmet need is and start measuring how much of that need we are meeting, and put that as our goal, as our ultimate goal. Thank you.
Thank you. And this really goes back to also the initial question, which is, concerning collaboration as well as what is important for us to measure. So it's very interesting how you've been able to also tie all those together. And next on this, I'd also like to hear what Dr. Thomas Burke has to also say about what some of the key defining success factors would be for innovation.
Yeah, thank you. So I think I completely agree with what Harshad just said, that those are critical features, and what we as public health professionals and in the development community really haven't paid attention to anywhere closely enough is that if an innovator or if a company that is behind an innovation isn't financially viable, there's no hope for that innovation to go to scale. And we've almost, in the development community, I would say over the last 30 years, have created a problem because, governments, the development community comes with the expectation that you're going to bring this innovation, this that hopefully has high impact potential. You're going to bring it for free, or that you're going to bring it, or that you can somehow afford to put in much more money than you could ever earn from it at its price point. And I have distinct examples around that, where a country says, well, to get through regulatory in this country, you have to have a certain amount of data. You have to give us a whole bunch of devices to these different hospitals. Then we'll go through the regulatory approval. And then actually to get into the supply chain is a whole nother, and by that time, a few years have gone by and you've spent more money you could possibly ever earn. So what it actually does is push innovations away from that setting. And we see that companies just won't enter markets. And so the population doesn't have a chance to have access to the quality of care that's possible. But on a granular level, innovations need to really be appropriate for the setting. So that means they need to be affordable. They need to be integratable into the system of care. They need to be acceptable by those that use it. And I love what Harshad said, they need to be acceptable by the actual recipients of care. They need to be easy to use, and there needs to be buy-in. And those are really, I think, critical elements from a granular level. But then the business part, the finance part is so often forgotten, and it's actually a critical feature of human behavior and incentive to make something go to scale. So thank you for having me, and thank you for asking.
Thank you, Dr. Thomas. Definitely all these innovations need to be easy to use, otherwise it would have been very difficult to actually get any value out of this. And that being said, actually, Becky, Antara is in the business of health navigation, a totally new concept in this market. Maybe could you tell us what are some of the key defining factors that you feel has helped Antara make health navigation close that gap of access in Kenya?
Yeah, definitely picking from what Dr. Burke has said in terms of the buy-in that clients have to get, or patients, the users of the innovative products that are going out to the market is very, very key. And that buy-in also touches majorly on the safety. How safe is this product to patients and to these users in terms of not going to do any harm, and equally looking at data protection also, not about just the health. People are very keen on how their health data is equally being used. Above that is about the convenience that this innovation is giving me, so that I can be able to access it. And at the end of the day, I also don't get into a catastrophic financial trap at the end of it. And as we are putting in efforts towards innovation, it shouldn't just be skewed to one aspect of health. Are we looking at primary healthcare, promotive and preventative healthcare, which is very, very key, and being able to assess the risk of various health conditions at an early stage, so that the management of these conditions also is very, very easy and it does not cause a huge burden in care.
Thank you, Becky. Those are very great pointers, particularly about, not being skewed to just one side of healthcare, but looking at everything together as a whole. And I think there's only one more person who's left here, and that's you, Gillian. Especially with your equipment, the innovation behind your equipment, how have you been able, what are the key defining success factors that have made you successful?
I would say for us, and I mean, even forward looking, right? So for us, it's about scale, and it's about use and implementation and the impact that it has on patients as well as on the systems where it's being used. So for us, it's getting into at the hospitals individually, as well as we just had to call it a national level in one of the countries that we're in. So seeing how this can scale and get into hands of every surgical team where we're at. So whether or not it be in Lodwar and rural Turkana versus again in inner city Nairobi, or in rural Ghana. So that's for us, we're getting into the hands of every surgical team to have that impact as well as that scale that Harshad was talking about. Is for us, scale is key for us to reduce costs and to streamline our supply chain moving forward. So.
Thank you so much, Gillian. And so today I'd just like to thank everyone who's joined us for today's webinar. I've just checked the questions section. I have not really seen any questions in there yet. And so I think we can just go ahead and conclude this session. And before we do, I'd just like to thank—
some questions.
Oh, you can have some questions on your end? Okay, great. Please read them out. Persis?
All right. So we have the first question coming in, and the question says, this is from Brennan. What are the biggest challenges Dr. Burke and Ms. Gillian have had in getting adoption and scale? I think the first question.
Yeah, that's a great question. So I've had a number of innovations over the years that have had various degrees of scale. Some of them have gone nowhere, and some of them have been fortunate enough to scale more broadly. So it really depends on how you define scale, of course. If getting across a country is one form of scale, but going across a continent or across a region is another form of scale. The greatest barriers to scale, I think, again, depends on what kind of an innovation we're talking about. If we're talking about a device, the greatest, assuming that you have a quality device, assuming you have all the collaboration we spoke of earlier, and assuming you have buy-in, actually there's a barrier from a device perspective that we don't think of very often in the development community, which is, I think, what Harshad and attested to, which is, for instance, in the African continent, there are perhaps 54 different regulatory bodies to try to overcome, and each of those countries then additionally has some kind of registration that may or may not be able to be figured out or navigable. And so then to hire consultants is money that's generally doesn't fit into a budget when really committed to global access and committed to a price point that's affordable at the lowest settings. So I think financing and regulatory is one of the greatest barriers that's unknown to the general development community when it comes to device scale, and the expense behind that. There really isn't a clear pathway in order to overcome that without suddenly losing the opportunity to serve the poorest or the neediest people on earth because the price point suddenly changes to incorporate all these other charges.
Thank you, Dr. Thomas. Persis, do we have any other questions?
Yes, we have a question from Neti Sanyao. And Neti is wondering, she's sure all the panelists have had first-hand account stories of a woman or a family member who's faced a health challenge. Can they share concrete examples where an innovation made a significant impact in that person's life?
That's a more personal one. That's very interesting. Yeah.
I think we all have examples, and that's probably what drives us to do what we do, and drives us as to why we're here. I think all of us are it's what lifts us up. I actually had 3 WhatsApp messages from India this morning on women's lives that had been saved by a uterine balloon. One in particular was delivering twins, became unconscious and was hemorrhaging, and a uterine balloon was placed, and everybody's excited and sent me a message. So those are the stories that really make my day in every possible way, and I'm sure that's true for all of us.
That's very
touching.
That's very touching. I believe actually everybody could share an account. Gillian?
Oh, I mean, again, this is where, again, cases for us where women come in and, again, need a blood transfusion and there's no blood available. And I'm sure some folks are aware of when you get text messages saying, hey, if you're this blood type, can you come and donate? So we're all about being able to provide a necessary resource for that patient whenever he or she comes in. So yeah, definitely see that as a big motivating factor for us, and as those continue to come in.
Becky, as a member of the care team, you are constantly, interacting with people literally on a daily basis. What are some of the accounts that you can share from, your experiences at Antara?
Some of the accounts are on innovation around point of care diagnostic tests that we've had. And that has greatly helped, especially with the pregnant population that we have been managing in terms of detection of early gestational diabetes and also hypertension management in pregnancy, so that at the end of the day, if it's hypertension, we are also able to make sure that things like preeclampsia are managed early enough, and these mothers are equally being followed upon. So point of care tests have greatly helped in follow-through care for this population.
Thank you, Becky. There's one last person
Okay.
I've not heard from yet. Dr. Harshad, I'm sure you've had.
I think I agree with all the speakers. For me, it is immense what you can do. I work with communities around the world in several countries, in Afghanistan, in Indonesia, in Kenya, and in Nepal, and working with community health workers and empowering them to save lives is so joyful. I'll give you an example of working in Afghanistan, where we are promoting prevention of postpartum hemorrhage at home birth, where women are having birth at home, not by choice, but by geography or other circumstances. And in providing them a solution, this is just use of misoprostol, community-based distribution of misoprostol. It was so amazing to see. And what I found amazing, one story, is when the district elders, the Shura, got together and said, all the community workers who go house to house to distribute this medicine, we are going to reward them by giving 2 young men who will go and repair their houses on the days they go and do these things. So there was a competition among the elders of different villages to support the community workers who were bringing life-saving care to their communities. And that to me was so thrilling, because community bought it. They understood the value of the innovation. They understood that lives of women were important. They understood that the people who were bringing these lives were important, were busy doing their other things, so they brought in the kind of reward that really got them. I think that kind of story energizes me, energizes the many people I'm telling the story to, and I think those stories need to be told. I think Thomas has great stories about his device. Gillian has great stories about this. I'm sure your other panelists has absolutely great stories. We need to tell the stories. We need to get our newspapers to tell those stories every day, because then I think people will start, there'll be a grassroots movement to want these kinds of technology and solutions that we bring.
Thank you. That is really a touching story. I'm actually just thinking about it. It must be very, very touching. Maybe Persis, is there any other question?
Yes, we have another question for Dr. Burke. And Esther Rita is saying, amazing about the PPH policy. How do you feel the implementation is going? As I know, implementation is not the easiest part when you innovate something.
That's a great question. The PPH policy, policy moves slowly, that's for sure. And, in the last, I would say, 2 decades of my life, where I've been particularly focused on PPH, I've seen policy changes in a number of countries, to include India, Kenya, and there's been a big shift in maternal mortality over these last 2 decades. So I think, just as Harsha described, focusing on the success animates people and animates our society to do even more. So that's the sort of the beauty behind originally the Millennium Development Goals and the Sustainable Development Goals, is to see how close we can get to hitting targets. But certainly more needs to be done. Finance, at the end of the day, seems to drive human behavior a great deal. So I think one of the greatest areas of focus that we need to really shore up worldwide, across low and middle income countries and beyond, is that we do actually ensure that there's finance and secure finance in order to support sexual and reproductive rights and health and especially for delivery services. So I think that's critical. But specifically, you know, I don't know if you had with this question, if there was a particular country in mind in terms of policy, but I think yes, policy, continuing to, you know, create policy and Ministry of Health guidelines that accompany policy. I think those are works in progress and need to continue to happen, but they happen slowly, no question. And I'll say as an afterthought that in many of the, you know, very low resource settings, WHO is essentially the de facto, you know, one where policies come from, and WHO moves very slow. Misoprostol is a great example. We all know how important misoprostol is, and yet I think, you know, WHO was easily 10 years behind in terms of adoption and putting out recommendations. So I think we should encourage countries to move beyond waiting for formal WHO recommendations, which so often are waiting for large-scale randomized controlled trials.
Thank you very much, Dr. Burke. We have another question, and this is for Gillian. Ashley is wondering, first she says, I agree with the comments about making innovation available by engaging in the market to fill unmet needs. So she is wondering, are you able to speak to the steps that were taken by Hemafuse as part of a team in the piloting phase of device creation to manage persistent leakage from female genital fistula that we are thinking about what should be in contact with and at what stage those conversations should begin?
Sorry, Persis, you're breaking up a bit. I'm not too sure if I'm the only person experiencing that.
Okay, let me say this again. Apologies.
Okay.
All right. So we have Ashley with a question, and she begins by saying she agrees with the comments about making innovations available by engaging in the market to fill an unmet need. And she is wondering if you are able to speak to the steps you took to scale up Hemafuse, as she is part of a team that is piloting a phase for a device that is created to manage persistent leakage from female genital fistula. And they're thinking about who they should contact and at what stage these conversations should begin and how to make that happen.
Okay, so I think this goes to also something that Dr. Harshad said as well, was getting your stakeholders organized early on for new devices or new innovations. So for us, again, I started with the end users and looking at the needs from an individual hospital, and then looking at more of the need across that. And it went from direct observations as well as interviews, and then even experiences that I had along with the blood supply challenges and the hemorrhage cases that were coming up in the hospital. But then it also goes to the administrators and the procurement staff, as well as what are they looking at for their hospital? Where do they see those costs coming from, and how can you also be a solution to them, as well as the end users, and even, as we've been saying, like the policy side. So who is engaged in the policies for that innovation specifically? So I would say it would be good to get all of that input for your design inputs, or for how you're looking to make this device and what you want to weigh for that, and then going through, and even with a concept device. So again, 3D printing or other rapid manufacturing techniques are really awesome today to even just get it out there and get feedback for what people are looking for, and to also do concept testing. I can tell you that we used a 3D printed prototype with super glued mesh and rubber bands in our first in blood bank study, or I should say study, for just 5 units to see what the quality of the blood coming out would be. And that's what really said, hey, we have something here. If this can work, we can then move on and gradually go on. So I would say it's all about leveraging the feedback and getting the buy-in at every stage of your development process, even if it's a very rudimentary early stage prototype that you have. And again, I'll just never forget the first hemofuse, which again, for all those that don't know what it looks like, it's a giant syringe. Having a clinician go to a nurse and him explaining how it works to his colleague, which I was like, okay, this is something where, you know, we're getting buy-in and these clinicians are showing it to others. There's something for us to move forward here. Again, even if it's the most low fidelity prototype you have to begin with.
Thank you, Gillian. I see Dr. Sangve has a hand up. Would you like to add something?
Yeah, I wanted to address, I think our questioner was asking about fistula and the horrible damage it does to women. And I think this is, in my opinion, this is a prioritization gap. And in fistula, it's a challenge. Do we want to invest in solutions for treatment of fistula? Or do we want to invest in solutions that prevent fistula? Or do we want to try and do both? In my opinion, solutions to prevent fistula already exist. And I think we should be really making an immense effort to prevent fistula, and those solutions exist. Let me give you another example. Today, 15 years after we have a solution for preventing the only cancer that we can prevent, cervical cancer, less than 5% of girls in Africa and maybe 7-8% in Asia have been vaccinated with the HPV vaccine. This is 15 years after this vaccine has been developed. We should not be investing in treatment of cervical cancer. We should not be investing in detection, screening. I created the single visit approach many years ago, but I'm telling people today the time is to invest in vaccines and making sure everybody gets the vaccine. It's a low cost vaccine. Even lower cost vaccines are coming. This is time to do it. So in my opinion, sometimes we get stuck in a prioritization gap. And I think that sometimes we need to take the innovations that are already there and try and use them. I feel terrible for women who already have fistulas. I do. I feel terrible for women who already have cervical cancer. But we have limited resources, and in limited resource setting, we need to choose the solutions, the innovative solutions that are likely to have the biggest impact on a population level. I believe the vaccine, HPV vaccine does that. I believe some of the solutions for preventing fistula will do that for us.
Okay, thank you very much, Dr. Sangve. I have a question from Jessica McKinney, and Jessica is wondering, could any of the panelists comment on experiences with knowledge of products clinically validated and commercialized in high resource settings that have been adopted for use and appropriately lower cost in low resource settings? I think all of you have so many examples.
Well, I will say actually what you just described is quite problematic and high cost innovations. So high cost medical products, for example, unless there is some entity like the Gates Foundation or other large donor that is willing to put in significant resources and try to adjust the business model, it's very, very difficult to get a company that's focused on and has a responsibility to its shareholders and investors to actually invest in a low resource setting. So you just described, I think, a high cost device. So those are difficult unless we get something like the Global Fund or the World Bank to put in a large amount of resources and go ahead and purchase to buy, something at scale, like anesthesia machines for all of the, for all of the regional hospitals in Kenya would be a good example, or surgical suites or something. And I always shudder when I see the price points that are spent, the many tens or hundreds of millions of dollars that are spent for those kinds of investments. So I think that there are a lot of innovations that are sitting on the shelf that, just as Harshad said, are it's really more about getting them out there than it is. Sorry, there's some noise. Yeah, getting them out there. In fact, there's a great study that was published and said when we know something new, this was in the British Medical Journal, we know there's something new. In high resource settings, it takes 17 years for it to be broadly adopted. And so, my goodness, we can think of settings where there are more challenges that it's going to take even longer. So I think really shortening those and finding ways to have there be appropriate for that setting innovations is, and the incentives are so distorted. I will just say, in high resource settings, I speak on this a lot, innovating for healthcare transformation. We in high resource settings make the tiniest advances, or sometimes no advance, but sell product for a much, much greater margin, or an innovation. A great example is, somebody's having a heart attack. 30 years ago, we gave them streptokinase, which cost $100. 10 years later, we were giving them TPA, which cost a few $1,000s. Now, 10 years later, everybody in high resource settings is getting acute angioplasty, which is $30,000 to $40,000 US dollars, and those kind of jumps. And now the world scientific literature basically says that's the standard of care. If you look at it critically, the outcome between acute angioplasty for heart attack and streptokinase is tiny. Yet in India, if you snoop around, you can buy streptokinase for $25 a dose. So we've left most of the world's community behind, does not have access to a solution for heart attacks, because we in the high resource settings have left them behind and said that this standard of care is one that actually the world generally can't afford. So I think it's shame on us in high resource settings who are so focused on making money that that it's very difficult to do what that question asked, which is translating knowledge and skills and ultimately products to the low resource settings. They need to be appropriate, and we need to be mindful of what's actually affordable and provide quality care.
Thank you, Thomas, for that answer. I've been emailed some of the questions actually, and this question I feel would be for Dr. Harshad. So somebody in the audience has asked, for the creative folks, how can we better tell the stories and tell them the narratives about positive solutions?
Well, I think each one of us is a champion, because we are breaking new ground, and I think we need to find appropriate media sources, social media, professional groups, parties, anything where we can talk about our solutions. And I think those stories can be amazing. These stories are very powerful. I just want to say that sometimes people are enamored with very expensive solutions. I'll give you an example of a solution where we compared a really low-cost simulator that we had created for developing countries to a very expensive simulator, birthing simulator, in our hospital at Johns Hopkins. And on all 8 educational parameters, this $500 simulator outperformed the $20,000 simulator. Think about that. So I think sometimes our notions of frugal engineering and how we are trying to design technologies for our sources actually can be useful to the developed world. Let's not aspire to those complicated, expensive technologies. Let us create the technologies that are essential and tell those incredible stories everywhere, because I think that story particularly is very dear to me, because we demonstrated to people that we can do things better, smarter, faster, and cheaper, so that everybody can get the healthcare that they want.
Thank you so much, Dr. Harshad. Does anyone else probably want to answer that before we move to the very last question? So in that case, I'll move on. So the last question is, what is the most authentic source of information on women's health? I think each of us here can answer that question. I'll start with you, Gillian.
The most authentic source, I would say from the patients themselves, I think, is to say that the voice of the patient and the clinicians, and secondarily the clinicians that take care of these women are the most authentic source. And again, we've talked about this being a driver for us and getting those reports on how our innovations can really affect, again, at an individual level. So that would be my answer, and pass it to my fellow panelists from there.
Thank you, Gillian. Becky, what would you say is the source of truth?
I think Gillian has nailed it, because the source of truth is definitely the primary stakeholder, who are the women. So that's where we can get the source of truth, and that truth needs to be documented, and data needs to be collated and structured in a way that then it can be used to better the healthcare delivery. Yeah.
Thank you, Becky. And Dr. Thomas Burke?
I think that's a fantastic question, as and Gillian absolutely nailed it, because if we look at policymakers and leaders in medical societies and decision makers, they look towards randomized controlled trials and quantitative research to guide, and put stamps of approval on what to do next. And it entirely misses what Gillian just pointed out, which is the voice of the women, and what actually happens between the cracks, and what happens when they truly have to walk the distances they have to walk, or overcome the many different barriers in their everyday lives and the social circumstances that they're confronted with. So I think that is absolutely the answer. We need more. I mean, from a research perspective, we need more mixed methods research. We need more authentic research around, and people need to respect well done qualitative research for that very reason. So yeah, I agree with Gillian.
Thank you for that. Dr. Harshad, I feel like this question still ties into
I think let's listen
about
to women. That's what I would say. Listen to your patients and listen to women. They've got it right.
Thank you so much for this very concise response. Thank you all. So I think that was the last of the questions that we had for today. So as we conclude, in the first place, I'd just like to recognize all our panelists who have joined us today and shared with us so much insight. Dr. Harshad Zangbi, Gillian Henker, Dr. Thomas Burke, and Rebecca Nyakundi. Thank you all for sharing your insight and expertise. Do you have any closing remarks, perhaps?
Well, just let me say thank you so much for organizing this the webinar. All right.
Sorry, I think we'll start with Dr. Thomas.
No, I just apologize. It's the 2 hours. Oops, I have another meeting I need to go to, so I apologize. I thank you all very much, and this was really fantastic and wonderful to be here, and I appreciate it. Yeah, take care.
Thank you so much. Anybody else? Yes, Yeah, Dr. Harshad, you were actually saying something
Yeah, well,
earlier.
just thank you very much to VIA for coordinating this webinar. Appreciate it, and excellent conversation.
Thank you so much. And Rebecca?
Yeah, great discussions here, and thank you for the opportunity and the platform. Yeah.
Thank you so much, Becky. And what have you, Gillian? Last but not least.
Yes, thank you to Via Global Health for putting this on. Thank you to our host here for asking all the questions and monitoring with us. Thank you so much to the fellow panelists. Really appreciate everyone taking the time, and again, a platform for women's health. So thank you.
Thank you so much. So to anybody else in the audience, if you do have any other additional questions, you can directly contact the VIA Global team. You can reach out to them directly through the email marketing@viaglobalhealth.com. So that's marketing@viaglobalhealth.com. So as I mentioned earlier, this webinar session has been recorded and it will be uploaded later on YouTube on both Via Global's channel as well as Antara's. So check in to see if you can find it within the next few days. Thank you once again all for your time, and have a wonderful rest of your evening or morning. Goodbye, everyone. I have been the moderator today, Leonida Combo from Antara Health. Thank you so much for joining us. Goodbye.